Hello, and welcome to another episode of Real Talk on Renal Cancer, sponsored by the Judy Nicholson Kidney Cancer Foundation with gracious support from Merck. I'm really excited today to introduce my guest, Dr. Hyung Kim from Cedars-Sinai. Dr. Kim is an amazing urologist in the community, and we're going to dive into just talking about all things kidney cancer, nephrectomies, and more. Welcome to the podcast, Dr. Kim.
Laura, thank you for having me. It's my pleasure to be with you. We've worked together at SWOG, and I know what a great advocate you've been for patients with kidney cancer, so it's my honor to be here.
Thank you so much. I really appreciate that. And you've been so wonderful to work with, and appreciate that you're always so inclusive of my voice and other patient advocates' voices. So thank you to you as well. So Dr. Kim, I wanted to ask you, there's so many different fields whenever you're in medical school to specialize in. And so what inspired you to go into urology and particularly working with kidney cancer patients?
Yeah, when I was a med student trying to figure out what I wanted to do with my life, I had never heard of urology until my third year of med school when I stumbled on it as an elective. It was the only elective that was left for me to take. It happened by accident, but I immediately fell in love with the kinds of patients and diseases we were urologists treat. You're able to do surgery in many cases and have an immediate impact on the disease. And that was very satisfying. You also got to develop a long-term relationship with your patients. It wasn't, even after the operation, you continue to take care of the patients often for years. And so those are the features of urology that really attracted me. Towards the end of residencies, when I got interested in kidney cancer, I wanted to focus on a disease where I thought there was a huge need for scientific advancement. And back in those days, we only had interferon and IL-2, and they weren't particularly effective. And I think that was one of the main reason I wanted to work in kidney cancer, seeing patients and doing research.
Yeah, back in the IL-2 days, that was dark. It was that there's some patients that thankfully have had some incredible responses on IL-2, but I've heard it's a very brutal disease, very brutal treatment. And so grateful that we have more options now. So I wanted to ask you, was there a moment or has there been a moment in your career that has really impacted your approach to patient care?
So the reason I think I'll answer the question by telling you why I became interested in cancer too. During medical school, and I noticed how resilient humans are, and their spirit, their ability to enjoy life in the face of disease was amazing, and it was inspiring to see that cancer patients sometimes seem to enjoy life ironically the most because they see how short life can be. And I think it was the inspiration I drew from the patients that attracted me to work in cancer.
Yeah, I love the way that you said that, Dr. Kim, because you're right. I know personally, I definitely look at life differently now than before I was diagnosed. And I think that's very common with patients. And it's really interesting to hear your perspective on it from the other side to see how that really does impact the patient's life and then also probably how they interact with their medical team. Thank you. I know that you have done an extensive amount of work in minimally invasive surgery, and that one of the things that we sometimes talk about on the podcast is nephrectomies and how that kind of decision is made between a patient and their provider. And since you've been involved in kidney cancer from those IL-2 days, how do you feel like minimally invasive surgery has changed outcomes for kidney cancer patients?
Yeah, that is an area that I can provide a little perspective because I'm one of the old guys. When I was training and then early in my career, we did a lot of open surgeries where we made big incisions that would go across the entire body, and patients would be in the hospital for days recovering, even more weeks recovering at home. And the ability to do surgeries minimally invasively was very attractive. You're doing operations through keyhole size openings. And so early on, we were doing laparoscopy, and the goal was simply to minimize the size of incisions. We saw patients going home earlier. We saw patients having less pain. And then the robotic technology became more mature and we started to use it for kidney cancer, we were able to do minimally invasive surgery, but do partial nephrectomies, where we can not only remove the tumor, but preserve kidney function as well. Right now, it's state of the art for renal masses is robotic partial nephrectomies. Obviously, some tumors are too big for that, but we're able to do partials for bigger and bigger tumors. And then the near future is going to bring us ablative technologies that may be totally non-invasive. And that technology is actively under investigation, and hopefully we'll start seeing that as well.
I love that because even though that laparoscopic surgery was around whenever I had my nephrectomy, my case was complicated enough that I had to do an open. And to your point, it was a long recovery. And so I think that sometimes we as patients don't always understand the risks that are involved with surgery and sometimes tend to minimize just how challenging it can be to recover from surgery. So it's great that we have these options now, and even better that we have non-invasive options coming along that hopefully will be here sooner rather than later.
Yes.
That's incredible. I know that now immunotherapy is a hot topic in kidney cancer treatment. And from your perspective, can you share with us how you see the role of immunotherapy in kidney cancer treatment today?
Yeah, so kidney cancer was always recognized as one of the two major cancers that were responsive to immunotherapy. So kidney cancer was one, melanoma was the other. And kidney cancer treatment really changed with the approval of the checkpoint inhibitors, mainly the anti-PD-1 antibodies. And we saw amazing responses, especially when compared to the older therapies like IL-2 and interferon. And of course, when these therapies were approved, we already had the TKIs like sunitinib and sorafenib, and they had pretty reasonable responses too. And what was exciting was to see the benefit from combining those two therapies. The outcomes were better than either one alone. And we saw a very important surgical principle being applied here. You take two drugs that have different mechanisms of action with non-overlapping toxicities, and then you can combine them to get added survival benefit. So right now we're using two agents, either two immunotherapy agents or a immunotherapy agent with a anti-angiogenic TKI, a tyrosine kinase inhibitor, to maximize the benefit to patients newly diagnosed with metastatic kidney cancer. But we'll make further advances when we can add a third or even a fourth agent. The key is that these new drugs that we add to get triplet and quadruplet therapy will again have to have unique mechanisms of action with non-overlapping toxicity. I think that's going to be the key. And each drug on its own may only provide a modest benefit, and that's okay. Again, as long as there are opportunities to double up and triple up on therapies.
I really appreciate that you said that about toxicities in particular, because sometimes as a patient, whenever I hear combination therapy, I get concerned sometimes about the quality of life too. And of course, obviously our main goal is quantity of life, but
Yes.
I appreciate that you also highlight that we have to consider the toxicities as well. And the pros and cons of that, because I think sometimes it gets overlooked.
Absolutely.
Yeah. I know that one of the trials that you're working on through SWOG is a trial known as Probe. I was wondering if you could share with our audience a little bit about that trial and how it plays into patients that are trying to decide on, do you do immunotherapy or do you do a nephrectomy first? And this is a common debate that we have in the community.
Yes.
On some people are like, I just want like my kidney out now. I don't care, just can't get out of me. And then some patients are like, maybe I should consider treatment first. And so would love to hear your perspective and then more about the trial.
Yes, thank you for giving me the chance to highlight this trial. I think it's an important trial. I want the uh, kidney cancer community, the patient advocates, to help support it. The trial is asking the question, should patients with metastatic disease have surgery to get their kidney with the tumor removed? Now, a pretty well accepted principle in oncology is that once the cancer leaves the site where it originated and metastasizes, that you need to treat the whole body with chemotherapy in most cases or immunotherapy, and that surgery to remove just part of the disease in the body is not effective and no longer has a role. So we're challenging that accepted paradigm in oncology by asking the question, should surgery be done? Patients, for the most part, like the ideal of having surgery because they see the CT scans with the big tumor on their kidney and they just want it out, even though it's not, there's other disease in the body. But I would say that there is potential harm in surgery. It can delay the systemic therapy, which is the real life-saving therapy in this situation. And you can also, people have argued that when you give immunotherapy, the tumor itself serves as a vaccine. So the immune system needs to recognize the tumor to fight the tumor. And so you're creating a cancer vaccine, which is the tumor itself. So by removing tumor, you have less vaccine for the immunotherapies. You can argue that surgery should not be done and that there are theoretical risks to doing surgery. Plus, everybody, whether they have benefit or not, has to suffer the pain of surgery and the necessary recovery. So there's that harm. And the potential benefit is there's less disease, the disease burden has been reduced, and maybe it gives the systemic therapy a head start. You've got the argument, it's all theoretical at this point. And what we're asking patients to do is participate in the study, help us answer this question by allowing for randomization. And patients often ask, why should I do this? And I tell them that the reason we have 5 FDA approved therapies for newly diagnosed cancers is because patients before you went on trials like this where they were randomized, and some of those patients didn't get the therapy that you're getting. They got a more inferior therapy, but because they did the study, now we know what to give you. And we're asking them to now pay it forward by participating in another study where we don't know what the right answer is. And they may end up getting the superior therapy, but they may end up getting the inferior therapy. But the future patients will benefit from their participation.
Yeah, I think that's a really great point because I think that for a lot of patients, myself included, whenever you are considering whether or not to do a clinical trial, you already are at a point where, honestly, whether you do a clinical trial or you don't know whether the treatment's going to work, right? So you're still making that kind of risk benefit calculation. And so what tipped me over the edge into doing a clinical trial was, at least to your point, this is something that will help other patients if it doesn't help me, because regardless, no matter what I do, it may not work for me. And so I think that's really a great point to highlight, that you really do have, yeah, if it's not a great situation, no matter
Yeah.
what, there is at least a benefit to doing a clinical trial. And so if a patient's interested in joining the trial, and I know it's randomization, and so basically their options are the arms. Maybe walk us through the arms of the study of what they could anticipate being randomized to if they were to join the trial.
Yeah, patients have to have metastatic kidney cancer, and then they will start by getting systemic therapy. So they're gonna get two drugs, either two immunotherapy drugs or a TKI plus an immunotherapy, and their doctor could choose any one of the five FDA approved combinations. And after 3 months of therapy, we repeat the imaging studies, and there will be a small number of patients where all the disease disappears except the tumor in the kidney. Now, those patients should have surgery because then the surgery will remove all radiographically visible disease in the body. So those patients should not undergo a randomization where they may not have surgery. So I think that's an important point. And then there's going to be a group where, despite therapy, the disease is rapidly progressing. And, that's a really tough, high risk group. And I don't think any of us believes that surgery can benefit them. So we also don't want to subject them to randomization and the possibility of being randomized to surgery when it's unlikely to help them. So the patients in the middle of those two groups who have either disease that's partially responded or has had stable disease, that's the group where we really don't know what to do. So that's the group that gets randomized to surgery versus no surgery, and then everybody is followed to see which group lives longer.
Thank you for walking us through that. And what I appreciate about the study design is that it allows quite a bit of autonomy for the patient and their provider compared to a lot of other clinical trials, right? So they can choose between the 5 different FDA-approved treatments, right? And then to your point, if they've had this great response, then you go ahead and do surgery, right? And you're not forced into randomization, which I think is really important to highlight because those are some of the concerns that patients typically tend to have, right, about joining a clinical trial. Dr. Kim, if a patient wants to join this trial after hearing about this, I know they don't have to go to see you at Cedars-Sinai. I'm sure you'd love to see them. But how does a patient go about, one, I guess, how would a patient go about potentially enrolling in the trial? And then two, from your perspective as a provider, how do you handle whenever patients come to you and say, I've heard about this clinical trial. What do you think about it for me? Because I know sometimes we as patients are nervous to have those conversations with our providers.
First, I start by thanking them for their interest in clinical trials, and we need more patients who think about clinical trials and want to participate. As far as enrolling in studies, the study is open at hundreds of sites all over the country, and I have no doubt there's going to be a study site within driving distance of everybody in this country. And you can start at the SWOG website, and the study goes by the name PROBE, P-R-O-B-E. And you can reach out to me. I'm sure, Laura, you'd be happy if potential patients reached out to you, and you can engage with us. You can engage with investigators at these study sites, and they'll look at your records to see if you're eligible. Even if you're not eligible for this study, I'm sure the people who you're going to be talking to who are experts in kidney cancer can provide insights and comments regarding the trial, your options, whatever stage of management you may be at.
Thank you for that. And yes, I'm always happy to talk to patients about enrolling in trials and pointing them in the right direction because, to your point, that's what we need. And I think I really appreciate that you said that you are so welcoming, which doesn't surprise me knowing you, but so welcoming of patients coming to you with trials that they've researched on their own because, again, I think patients just sometimes feel a little intimidated having that conversation with their doctor. And so appreciate that you're so open to that because it makes a difference. So, Dr. Kim, I know that outside of probe, that you also have, that you and your lab have done some work on biomarkers and cancer vaccines. And those are other hot topics within our community. And so, how close do you think that we are to having personalized precision kidney cancer treatments?
Yeah, I think that we have lots of therapies and we have lots of information even now on who benefits from those therapies. So I think the era of precision medicine is here, and we can sequence tumors and in blood cells for very little money now within a day or two. This is a kind of stuff that used to take hundreds of millions of dollars and decades when I was in training. We've come a long ways. There are lots of really exciting therapies on the horizon. And as you mentioned, I run a small laboratory in addition to my clinical practice. And we've been targeting a immunotherapy molecule called FOXP3. And it sounds like an obscure protein, but the Nobel Prize in medicine was just given for discovery of this very target. So I was like super excited to hear that the cancer target I've been working on for 10 years, I didn't discover it. People before me did, but the people who discovered it just got the Nobel Prize. Really exciting.
That's really amazing. Gosh, working on that for 10 years, and it's really
Yeah.
incredible to hear that your decade of work has not gone in vain. Dr. Kim.
Others are catching on. They recognize that
Yeah,
there's going to be a lot of people jumping on this target research.
that's awesome. Shifting focus a little bit as we wrap up. Obviously, again, I know you have a big focus on patient-centered care, and how do you help patients and their caregivers navigate those emotional and psychological challenges of a diagnosis whenever they're in your clinic?
Yes, I think patients appreciate it when you, at minimum, recognize what they're going through, the trauma of finding out about the diagnosis, and the sense of being overwhelmed when you start to do research. In most patients are not trained in medicine, and so the terminology, the options, and then there's also the marketing that's out there as well, trying to figure out what's real, what's marketing. It's really overwhelming, and I think patients need to just understand that we understand them. And then ultimately they need to have their disease stage characterized and treated. And you need to just be able to provide their care very meticulously in a very organized fashion. You need to be able to lay out the options for the patient so that you involve them in the decision making. And you want to provide an environment where patients and their families can trust the care and the care team.
That's so important because I say often that I feel like patients are having to make what feels like and what usually is the most crucial decisions about their care whenever they know the least about their disease. Like now, 9 years in, I hope I don't have to make any more decisions again. But if I have to make more decisions about my care, I feel much more confident in what I would decide. And because I understand my disease a lot more than I did. But whenever I was first diagnosed, like I hadn't thought about my kidneys since like high school biology. So I think that it's great that you're empowering patients and their loved ones to, with that knowledge and being able to make informed decisions because we look to you all as professionals to help us anyway, but even more so in those early stages. That's like the scariest time.
Yeah. And as a physician, I work with the team, right? And the team there's the nurses, the case managers, the schedulers, everybody is there to support the patient. And the patient is the center of all our focus, and it's challenging enough for them. We want to make the care process as smooth as we can, and we can make it. And it's great that patients also have other patients to turn to. I think that's the truth is often they trust a fellow patient who's navigated this even more than the doctors. And I think that's a trust that's well placed. And it's a tough time, but there's help out there.
Absolutely. Yeah, absolutely. And I think that's, again, something that we focus on at Judy Nicholson Foundation is providing those safe outlets of being able to, whether it's an open forum or our support groups online, just having that place for patients to safely ask the big questions and sometimes the little questions that you're like, is this something I should ask my doctor? Or is this something I should worry about? And none of us are medical providers, but we can at least say, oh yeah, I had that happen while I was on this treatment. Or, ooh, yeah, you should be asking this question from the ER, not from your living room. Yeah, no, thank you for that. On a lighthearted note, as we wrap up, what's your favorite way to unwind after a long day, either in the OR or in your clinic? What's your favorite thing to do?
I love to go for a run, and I am blessed to live in Southern California where I can do that all year round, even late at night when I get home.
Yeah,
So I put on my running shoes, turn on some music, and just run off into the dark.
I love that. That's great. Are you like a heavy metal guy or are you like soft rock, like yacht
Soft
rock?
rock,
Okay.
soft
All
rock.
right. I was like, you say something crazy, I'm gonna forever change my opinion. I'm just kidding. Dr. Kim, thank you so much for your time today. Appreciate all that you do. Again, it's wonderful working with you at SWOG and appreciate all that you do for your patients. And thank you for sharing all the incredible work that you're doing too. I know our audience will be thrilled to hear about the exciting stuff in the pipeline. So thank you.
Thank you for the invitation. I love talking about this stuff, so please have me back.
I I will take you up on that.
All right.
Thank you again. This has been another episode of World Talk Renal Cancer, sponsored by the Judy Nicholson Foundation. Again, thank you to Merck for your support of this podcast, and we will see you again soon.